Hello and welcome to Fire Headlines, where we discuss the hottest topics in fire service news. I'm your host, Samantha Didion. We're slowly transitioning into our new format, focusing on key takeaways from industry thought leaders and subject matter experts, while bringing you face-to-face with the conversation. Head over to our YouTube channel or follow us on social media, where you can now watch the Fire Headlines podcast. Today's topic is rural emergency response. An article recently shared in the Daily Dispatch discusses how Minnesota lawmakers are considering spending $6 million on a pilot program to test the use of what they're calling sprint paramedics to help battle the state's worsening rural emergency response. I'm really excited to bring you two different aspects of this article from this week's panel. Joining us today is our very own Chief Bob Horton, along with WFCA's president and the fire chief of the Boise, Idaho Fire Department, Chief Mark Niemeyer. Mark is going to ease us into this topic, focusing on how to set a pilot program up for success and what considerations need to be in mind for rural emergency response.
So as I read the article and thought about this, a lot of questions came to mind. Certainly there's a need, right? And it's a need across all of our states in the West that I have visited. And then as you look across the country, certainly the West is not alone in this. This is a challenge in every state. In those rural communities, how do you get quick response, advanced life support to people in need? There's a cost to it. There's a recruitment and a retention challenge to it. We could talk about those things. There's a scope of practice work to it. And then quite honestly, from a hiring standpoint, hiring really competent paramedics, because in rural areas, those transport times tend to be an hour, 2 hours, 3 hours, just to get to a primary care facility. So with any pilot, the first thing I thought of is what benchmarks. I'd love to see the benchmarks they develop to look at what the desired outcomes are. Is it simply response time, which so much of our fire service is measured off of, where you get there in 5 minutes or 10 minutes or 11 minutes and okay, we met a benchmark. But deeper than that, looking at the patient outcomes. So if we provide an ALS quick response, and it sounds like in Minnesota they're looking at putting one paramedic on a sprint car. We provide that quick ALS, and there's obviously a BLS or some kind of transport component to it as well. What are the ultimate outcomes of the patient? Whether you're talking MI, strokes, whatever you're talking about, trauma. Are we receiving and seeing better outcomes? So I'd love to see those benchmarks. Response times are fairly easy. It's start and stop. We measure those. But then what other benchmarks are we looking at? I think one of the ones that I'd be interested is what's the overall experience of the paramedics on that sprint car. It's a single role paramedic, probably driving in a pickup or some hybrid or something, some kind of vehicle. And so after the trial period or the study period, what was the experience of those paramedics? Did they enjoy it? Did they find better outcomes? It's interesting thinking about a paramedic going to a very rural community. Either A, they have to live there already, or they're moving in from somewhere else. So how do you recruit for those paramedics? And I started thinking about that. And the challenge with, that's real medicine. If you're going to do that, that's long transport times. You're with a patient for a very long time on those rural transports. So certainly I would use that as a tool to recruit and attract. But then you also look at call volume. And we all know in the fire service, the busier we are, the better it is sometimes. We're out and engaged and active. So what's the call volume going to look like in a rural community? Is that enough to keep good paramedics functioning into that role, into that study? So that's another one I thought about. Retaining would go right along with that. If the call volume's not there, if the support is not there, are paramedics going to stay and want to work in those areas? And then how do they integrate? How do you integrate a sprint paramedic vehicle funded by the state, in this case in a study, or potentially funded by the state? And then how do you integrate with other local EMS, local fire? In some areas, it's a sheriff responding in a dual role. So how are you going to integrate protocols, integrate all that work? That's a good challenge. I think funding is an interesting one for me as I read this. The fact that the state is willing to consider funding the opportunity to see if this works. And I know in my state in Idaho, we have talked about rural EMS for a really long time. You have good EMS coverage in the areas where people live and congregate. But as you travel through our state and you recreate, you're traveling through areas that literally have no coverage. And there was a big 2-year study that went on here in my state, and we're not alone. A lot of states have been looking at this, trying to engage and trying to figure out how do we make sure that EMS is provided, that coverage is provided across the entire state. So really cool pilot. I'll be curious to see how it plays out. Again, I'm really focused on what are the benchmarks and outcomes that they're going to shoot for. And then really what's the engagement of the people doing it? Did they enjoy it? Did they find value in it? Certainly we're all about the mission. And if the work we do aligns with the mission, I think firefighters, paramedics, EMTs organically rally around that. They love coming to work. But if you feel like you're not doing much that aligns with a core mission of service to the community, better outcomes, it gets a little rough. I know I faced that in my career. So happy to see where this goes. Thanks for allowing me to join you on the Fire Headlines podcast. Look forward to chiming in a future date.
Thank you for those insights, Mark. We're going to switch gears and hear from Bob Horton now on a more academic approach pertaining to systems and hear about some larger issues that might be at play here.
So this is a modification of a system. It was W. Edwards Deming, who is considered the godfather of the total quality management movement, who said that every system is perfectly designed to get the results it does. So with the emphasis there that Edwards Deming wanted us to understand is that we need to look at the entire system of what it is that that's causing these challenges that we're trying to face. I mean, we've talked about this on the show quite a bit. This is about demand exceeding supply for EMS services. Our system is designed on the wrong fundamental assumption, which is that access to 911 services is for emergencies. And maybe that's what the system was originally intended for. But the intersection of this with other social service systems and so on and so forth has the EMS system largely becoming a medical access point of first resort in some cases, not last resort, not as a result of an emergency, but as a result of some acute need that could be socially driven or medically driven. So it's put this undue demand on our emergency services, and it's causing us these challenges. And so if we look at what the system is designed for now, it's a lot about what we're getting. The article talks about it. I won't get into a lot of detail, but it's talking about insurance reimbursement methods. And the reality is that is a true barrier that ambulance systems are facing if your model is dependent on that income. And I say it that way because we run fire departments who run fire resources that are based on a tax-funded system all the time. But all of a sudden, when we get to ambulance, we stop thinking about that. We look at what reimbursements are telling us we can and can't do. So we spend a great deal of money without really modifying our system. So this community is looking at how do they modify a system in a way that makes more efficient sense. I like that we're unpacking that. So a couple of things. Fully loaded ambulance. What does that even mean? So ambulances that transport patients from a scene to a hospital or wherever they're transporting through has to meet regulatory requirements. It has to have certain minimum number of amount of equipment, amount of personnel, so on and so forth. And all of that has a cost. A lot of the costs on an ambulance are, let's say, medications that are going to expire if they go unused. So how many ambulances do you actually need? If you stopped at that outcome and say, how many times does someone need to be transported to the ambulance? It's not lost on me that you have to move someone from A to B in an ambulance for you to bill insurance to get reimbursement. I'm not talking about that right now. I'm talking about patient condition warrants somebody has to be moved from a scene to an emergency room. And my guess is it's going to be a very small percentage of your total call volume where someone needs definitive care at an emergency room. Yet in most of our systems, that's the only choice. Your regulatory positions tell you that's the only way you can do it. And a lot of those regulatory positions are because that's what the insurance industry says has to be done for you to get a reimbursement, for you to bill and get a reimbursement. But what if those weren't pieces of your model? What if you wanted to just send care to somebody's house, do an assessment, determine the need for an ambulance, and only utilize that ambulance when necessary? Well, that's a different model. And that's what this community is looking at exploring. So rather than saying we need 10, 12, whatever the number is, fully loaded ambulances with all of this equipment. But I mean, to me, it was sort of astounding. You had to have, a whole set of gear that a paramedic team would take into a scene with them, and then they'd have that same, like, a duplicate set of all of that stuff in an ambulance, like a mobile office with extra restock, because you may need to go from hospital to patient. Point I'm trying to raise is that's all added expense to a system. So, another case of sprint medics, or whatever this is, it's a creative name they have for them. We called it in our district our community care team, where you were looking at alternative deployment of resources to get on scene, do an assessment, and determine the appropriate next step. We can predict a good amount of that in our 911 system if we're collecting that kind of data and analyzing it. We've done another conversation on that. But the point is in optimizing your response. And what I want to highlight out of this article yet again is, if you can get away from thinking about your funding model being required to be determined by what insurance will or won't reimburse, you can really build a healthy EMS system.
Thank you, Bob. And now to our listeners, we want to hear from you on what your takeaways or thoughts were pertaining to this topic. Head over to our Instagram, Facebook, or LinkedIn to continue this conversation. As always, thank you for tuning in. And if you have a question for the panel, please reach out to us at fireheadlines@wfca.com and let us know what's on your mind. We'll see you back here next week for more Fire Headlines.